can turn our cameras off and we can pretend this is like, you know, oh my God, like 2019, and we just like did a audio call. That's awesome. So Dr. House, can I introduce you? So welcome to our Relational Coordination in the VA book club. We often will be going through some of Dr. Catel's books, but today we get to have you with us, which is exciting. So I found Dr. House's work. Well, actually, we connected at the Relational Coordination Collaborative, whenever that was, recently, and she's doing a lot of work with in the military world that we're trying to do in the VA, which is just amazing. So I think we have lots and lots to learn from you. Plus, she's a postdoc at Indiana, which is super cool. So your community here, your little audience, we actually are all practitioners in the sense that we're all clinicians. We have social workers and we have nurses and we have program managers and we have a bunch of PhDs on here who are not just doing research around relational coordination but we're doing it in practice. So we have an implementation science arm as well. So we're excited to hear what you have to say, and I will just let you take it away.
Now, will I be able to advance my slides since you're sharing?
Yeah. Tell me what to do.
I'm sorry, say that again.
So just tell me when to fast forward, and I will go to the next one.
Thank you. Okay, so we can start. Again, my name is Sherita, and I'm a postdoctoral fellow at Indiana University School of Nursing. I'm also a critical care nurse in the Navy Reserves. I've been in the Reserves for 12 years. And my research focus is health services research and staff outcomes in acute care settings. You can advance, please. Thank you. So my early research focused on interprofessional collaboration among nurses and physicians. And so I conducted a study in a civilian hospital among nurses in the ICU. So I had 3 ICUs, and I had 8 med-surg units, and I explored their perceptions of nurse-physician relationships. And then I've also done a systematic review with Donna Havens that looked at nurses and physicians' perceptions of nurse-physician collaboration and relationships. And for my dissertation research, I graduated from UNC. So I'm sorry, I have to say this, go Tar Heels, super proud of them. So for any Duke fans, I'm so sorry. But I did my dissertation research. And the title of it was
we have a UNC house on the call, and then we have a Kansas house on the call. So
yay, super excited. That's awesome. I conducted my dissertation research in January 2020 through March 2020. And I looked at military and civilian healthcare professionals' experiences of relational coordination, job satisfaction, and intent to stay in a military treatment facility. And this facility was actually an Army hospital. You can advance, please. So some scholarly work that I've done so far, I've written 4 manuscripts from my dissertation research about relational coordination. So the first manuscript that I wrote was Relational Coordination and Staff Outcomes Among Healthcare Professionals. And this was a scoping review. And then I also, when I conducted, again, my research, I wrote 2 research-based papers. So one was Relational Coordination as a Predictor of Job Satisfaction and Intent to Stay among Nurses and Physicians in the Military Health System. And then another was Relational Coordination among Nurses and Physicians in an Army Hospital. And this manuscript explored do demographic characteristics and professional roles matter? And then I also wrote a manuscript about using relational coordination as a framework for healthcare leaders during a merger and acquisition. You can advance, please. You can advance.
Oh, I think I did. Did it not go forward? Sorry, let me try again.
It's okay.
Oh, it did.
It
now
did.
It is. Yeah, now it did. Earlier it didn't.
There you go.
Thank you. So pretty much what I found, so the first again was a scoping review. And this scoping review was relational coordination and staff outcomes among healthcare professionals. And the aim of this review was to really explore what is known from the literature about relational coordination and staff outcomes among healthcare professionals. And the search strategy that I used was I looked at manuscripts in PubMed, Scopus, CINAHL, and PsycInfo. And I used these databases because they contained journals that targeted allied health professionals. And I specifically just used the search term relational coordination. And the reason I did that is because, as we all know, relational coordination is very unique. So I thought, rather than looking at coordination, initially I started off in that direction, but I noticed I was getting so many manuscripts that had nothing to do with relational coordination. So I went back to my dissertation committee and we discussed, just using relational coordination as a search term, since relational coordination is unique. And that's actually what I'm interested in exploring. So from that, I found 11 studies, and pretty much relational coordination was associated with better staff outcomes, such as better work engagement, higher job satisfaction, lower burnout, reciprocal learning, and employee motivation and innovative ideas. There were 2 studies that I found in relational coordination was not significantly associated with staff outcomes. One had to do with nursing turnover on the unit, and another had to do with work engagement. You can advance, please. So the next thing, after I did the scoping review, of course, I found that I really haven't seen where relational coordination was explored in military treatment facilities such as Navy hospitals or Army hospitals or Air Force hospitals. So I thought, given the unique structure in the military, I thought it would be kind of interesting to explore relational coordination in this setting, especially since you have these formal hierarchical ranking structures. And we all know that, high quality communication and high quality relationships are important for not only staff outcomes, but patient outcomes as well. So in this study, I wanted to see if relational coordination was a predictor of job satisfaction and intent to stay among nurses and physicians in an Army hospital, but the title, of course, in a military health system. And this study was a cross-sectional exploratory study. And I conducted this study on 12 patient care units, and the units were the ER, the OR, PACU, L&D, NICU, ICU. So I had a variety of units, and those are just a few that I named. And the sample were military and civilian nurses and physicians. So for nurses, it was LPNs and RNs. And for physicians, it was physician residents and physicians. And recruitment occurred via flyers and emails and face-to-face. I really had to really physically go to the study site. I lived 2.5 hours from the study site and do some heavy recruiting, especially for the physician group. They were a little bit tougher to recruit. For the nurses, they weren't as difficult to recruit, but for the physician group, I had a little bit of a challenge. But it was a fun challenge, and I learned a lot. And I'll tell you about my experiences in another slide about, my experience with data collection in a military hospital. So I used a 47-item survey. And for the results, most of the sample was predominantly nurses. So it was 75% nurses. When I say nurses, I mean registered nurses. And I had 46 physicians and physician residents. It was 10 residents and then 36 physicians. And I also, most of the sample was predominantly civilian. So it was 70% civilians, so 203 civilians. Then I had 86 military healthcare professionals. So the good thing is my sample was representative of the healthcare professionals in Army hospitals. In Army hospitals, they are predominantly civilian. So you may have a ratio of 70% civilian and 30% military. Whereas in your Navy and Air Force hospitals, you have a higher percentage of military healthcare professionals in comparison to civilian healthcare professionals. For the data analysis, for the bivariate analysis, I used t-test, Pearson correlation, and one-way ANOVAs. and then to explore the question if relational coordination was a predictor of job satisfaction and intent to stay. I used multiple regression, and I also did a mediation analysis. So what I found was job satisfaction was significantly associated with intent to stay, and relational coordination was associated with job satisfaction. Relational coordination within roles was associated with intent to stay, and then job satisfaction mediated the relationship between relational coordination and intent to stay. So I was super excited about those results. Can you advance to the next slide, please?
Can you see it? I just did.
Yes, thank you so much. Thank you. And so the next study, again, this is from my dissertation research, and I also explored relational coordination, of course, among nurses and physicians. And I wanted to see, do demographic characteristics actually matter? So demographic characteristics in professional roles. So the demographic characteristics that I explored were race, age, sex, and rank. And then, of course, the professional role was whether they were a nurse or a physician. And I found that professional role, race, age, sex, and experience were not associated with relational coordination. However, rank was associated with relational coordination between roles, and enlisted service members reported the highest RC. And then education was significantly associated with relational coordination within roles. And people with, I'm sorry, I'm having a hard time seeing this bottom part. Whoops, oh my goodness. Let me go back here. Oh, what just happened? Oh, I think it went down here. Okay, so people that had more experience, or excuse me, people that had, I think this says less experience, or more experience had lower relational coordination. Okay, you can advance to the next slide, please. So the last study that I did with relational coordination had to do with relational coordination as a merger and acquisition framework for healthcare organizations. And I came up with this because during my dissertation research, I think many of you may even already know that military treatment facilities have transitioned to the Defense Health Agency. So as you can imagine, if you look at the different military treatment facilities, so your Navy hospitals, your Army hospitals, your Air Force hospitals, they all had, different processes. They had a totally different culture, a different way of doing things, different policies and procedures. And they were told, effective October 1st, 2019, hey, guess what? You're all going to come under one umbrella, the Defense Health Agency. So if you just think about that huge transition, I know that they had put that on hold, but the last I had heard, they resumed that, I believe, in April 2020. And so the military treatment facilities are now all under the Defense Health System. And I thought, well, gee, Sherita, maybe write a manuscript that would be applicable to both military and civilian healthcare leaders, not just for the military. So I wrote an article about how, again, healthcare leaders could use the dimensions of RC during a merger and acquisition. So I took each dimension of RC, and I first, just explained what RC is, because most people that I come across are not really familiar with RC. And I explained, the dimensions and defined the different dimensions of RC. And then I looked in the literature and found how, different healthcare professionals in both civilian settings mainly and, military healthcare organizations have experienced like what their experiences were during a merger and acquisition. And one of the main things that I found was that during merger and acquisitions, you have a lot of communication failures, and some researchers report that participants reported low quality communication. So I thought, gee, relational coordination will be the perfect framework. And in the last part of the manuscript, I talk about how to operationalize each dimension of RC during a merger and acquisition. So as you can see, I have a table here, and I give the dimensions of relational coordination, and then I suggest an intervention to help improve each dimension of RC. Okay, you can advance, please. So this next slide is just going to discuss some limitations of my dissertation research and some lessons that I learned in conducting this study in an Army hospital. So of course, the obvious, this was a single site study. It was cross-sectional exploratory, so we can't really say causality. We did see different associations, and so I was glad to see that relational coordination was significantly associated with both job satisfaction and intent to stay. Another thing was, of course, the low number of physicians and the sample of 70% civilian. And so my thought is to consider conducting this study in a Navy or Air Force hospital because they have a higher number of military healthcare professionals compared to Army hospitals. And then something else, I only conducted this study among LPNs, RNs, physician residents, and physicians. And the reason were a few. The first one is nurses and physicians comprise of one of the largest disciplines in the healthcare workforce. And then the Research Council at the study site recommended that I only select a few healthcare professionals to collect data from. And they mentioned that at this particular site, they are inundated with surveys. And given that, they didn't want to continue to, do survey after survey. And so, as you know, with relational coordination, for each work group you have, there's 7 relational coordination questions. So I had a total of 4 work groups, LPNs, RNs, physicians, and physician residents. So that meant that was already 28 relational coordination questions, not including the job satisfaction and intent to stay. So I selected only nurses and physicians based off of recommendations from the Nursing Research Council. And so future research should really consider, exploring relational coordination among other healthcare professionals. So lesson learned. My experiences with data collection in an Army hospital. So what I learned was relational coordination with eligible participants actually matters. Having effective recruitment strategies, frequent face-to-face interactions, and high-quality communication. I gave participants, and I'm sorry I didn't mention this previously, but I gave participants the option to complete their survey electronically or via paper and pen. And the reason I did that was because whenever we sent the survey electronically, there were issues with the firewall protections. And so I would go, maybe once a week during data collection just to see how things were going. And the participants would say, Sherita, we never received your survey. And I'm like, oh my goodness, no, it's going out. So I reached out to Relational Coordination Analytics, and they had mentioned, yes, Sherita, we have distributed your survey, talked with the nurse managers. And what we came up with whenever I called information technology was that it's probably related to the firewall protection issues. So I added an additional way for participants to complete the survey. And I placed survey lockboxes on the units in designated areas. And I advised participants that they could also complete the surveys, via paper and pen, and just place their survey in a locked survey box. And I went each week to collect the surveys. Well, what I found was that kind of worked. I did get a few more surveys, but what really worked for my research study was the face-to-face interaction with the survey in hand. And it was a very careful balance of not being too aggressive, because of course this study was voluntary, but to also make sure that participants knew about the study, because in speaking with them, sometimes they would say, well, Sherita, I haven't even heard about your study. And I'm like, what do you mean you haven't heard about it? I've posted flyers, I've sent emails, but I think they just had, so many other things going on to where it was just, oh, this is just another flyer. So what I found to be the most effective was face-to-face interaction. And interestingly, I collected more surveys the last 4 days of data collection than I did the entire 6 to 7 weeks of data collection. And it was really more about, once I was looking at the numbers and I saw, gee, based on the power analysis I did, I'm not going to meet my goal. I really had to spend time on both day and night shift, just really making sure that people were aware of the study, talking with the different participants. And you may say, well, Sherita, I'm conducting a study, in another state, or another county that's, further away. I don't have the option to go and do face-to-face recruitment like you did. And my suggestion would be to really have some type of liaison or some type of site coordinator that's really going to put the pedal to the metal and help you obtain your data. The other advice that I would give is if you do conduct research in a military hospital, and if you do have firewall protection issues like I did, I recommend that you really make sure that you advise participants not to complete both the paper and the electronic surveys. And I did that by making sure that I sent emails. I posted that information on the cover letter of the study. And I also made sure to communicate that during my face-to-face meetings. I talked with nurse managers and asked them to mention that, as well as the physician leaders. So that was a concern, was, that participants would complete both the paper and electronic surveys. But I tried to remedy that by really making sure that that was communicated orally and on written documentation, like the recruitment flyers and the emails that I sent and the cover letter of the actual survey. Next slide, please. So this is the last slide, and this has to do with next steps. So my next steps are to conduct 2 relational coordination intervention studies. A lot of researchers have looked at cross-sectional observational studies regarding relational coordination, but I haven't seen a lot of relational coordination intervention studies. And specifically, I'm interested in, improving staff outcomes. So the first study that I'm interested in conducting is Relationships Matter, Improving Job Satisfaction and Intent to Stay in the ICU through relational coordination. And I found out Friday that I finally got IRB approval, so I'm super excited about the opportunity to conduct this study this spring. And the aim of this study will be to determine the feasibility and acceptability of conducting an RC training intervention among healthcare professionals in the intensive care unit. And this design will be a 4-group pilot intervention study, a parallel group randomized control trial. And the intervention that I'm thinking of using is a virtual relational mapping exercise, which is why Dr. Gilmartin and I connected, because I know she's done a relational mapping virtual exercise. So I was really trying to pick her brain to find out, lessons learned and just her experience with that. And so I will collect data at baseline, and then I will conduct the virtual relational mapping exercise. I'll begin the intervention just by discussing what relational coordination is and going over the dimensions. And then I will do the relational mapping exercise with participants. And then I will go over with participants how they can actually operationalize relational coordination on their unit. And the sample will be so providers, physicians, physician assistants, nurse practitioners, nurses, and respiratory therapists. And this study will be conducted in a civilian hospital. Something to note is that in this hospital, they don't want face-to-face research being conducted as far as data collection goes. So I'm going to do this virtually. And in the next study, I will go back to the study site that I did my dissertation research, and pending IRB approval, I will look at Relationships Matter, Improving Job Satisfaction and Intent to Stay in an Army Hospital. And so the goal is very, similar, just to determine the feasibility and acceptability of conducting a relational coordination training intervention among nurses and physicians in this case. But the design will be different. It will be a single group feasibility study, and the intervention will be different. The study site that I did my dissertation research, they are allowing face-to-face data collection. So I'm going to do 3 one-hour lunch and learns. The first lunch and learn will be just exploring what is relational coordination. And then the second lunch and learn will be the relational mapping exercise. And then the third lunch and learn will be how to operationalize relational coordination. And the sample will be nurses, physician residents, and physicians. So next slide, please. Finally, the last slide. Thank you for allowing me to discuss this research with you. I really appreciate your time and attendance. I know you could be doing several other things, but I appreciate you inviting me to speak, and I apologize for the technical difficulties I have had on my end with Microsoft Teams, but I'm happy to answer any questions you all may have. And again, thank you for your time today.
Dr. House, that was great. Thank you so much. Your work is so interesting. I have to tell you, you could not have a better group of people on this meeting right now, because as you and I have talked, we had to switch from in-person plans to do relational coordination mapping and education to virtual because of COVID. And so if I could call out the dream team here, which is Rachel Kenny, Heidi Schoberg, and Bree Morgan, who actually have been doing this.
Yes.
So Heidi, I'm sure you were laughing for some of it, right? About getting survey response rates. Do you want to tell some of the stories?
Yeah, I totally was. And I was like, when you mentioned that you're going to be doing, or that you recommend having like a liaison person to like sit down with people and do the survey in person, I was like dying and thinking that there's no way any of our sites can do that, or that they have time for that. So kudos to you.
Thank you.
Yeah. Yeah. So, I mean, honestly, we've done the RC survey with one of our sites, and our response rate was 5 out of like 30 people. Mm-hmm. And we're doing it at our second site, and we're in the middle of it. So I don't know how many people are going to respond, but we sent it to about 50 people. So I guess we'll see who responds. Mm-hmm. But yeah, I mean, that has been a huge barrier for us. So outside of having somebody sit down with people and fill it out, do you have other advice?
Heidi, what was our brilliant adaptation? So we've been tracking adaptations along the way, because we started off, Dr. House, with a very similar approach that you did, and it all got thrown away because we couldn't go on site visits. No, everyone has survey fatigue. We had the firewall issues as well. So Heidi, I'll let you, where do you start? Well, no, okay, gosh. Can we even go backwards? Can we start with the mapping?
Yeah.
Start in the beginning. Yeah, go.
Okay, yeah, so with the mapping, we actually, and if Heather's talked to you about like how she's done it, she maybe has told you about how we're doing it now, but we've had to do the relational maps, virtually with our sites, but it's been like over time. So we have weekly or bi-weekly site meetings with each of our sites, and not all of the providers are able to attend every site meeting. And so in order to capture all of their input, we've had to do the RC mapping exercise in like 2 to 3 meetings with with all of our sites, just to get like the names of all the roles who are involved, and also to talk about like the actual strength of the relationships of communication between each of the roles. So that's been a process. We've also tried to pull the roles we have our qualitative team does interviews with with personnel from our sites, and then they develop process maps based upon that. And so we've tried to pull roles from the process maps, but then it's like, sometimes the process maps are a different process, so they don't even capture the roles that we're working with our sites. Yeah, so that's been an experience. And then even getting names for people to include in the surveys has been really challenging for us. Like a site that we worked with, our first site, wouldn't even give us names and email addresses of anybody that they collaborate with. And so Bree was doing like freaking chart reviews to find out who was co-signed to certain notes. And then we got all the participants for our survey from that.
Wow.
So.
And then we were asking the team too, was there a better way to do it than the chart reviews? And they said, no, the chart review seemed like a good idea, but it didn't really yield
anything.
A single response, right? Like not a single response.
Yeah.
So how far are you from the actual study sites as far as distance goes?
Well, so I live in Colorado. None of them are in Colorado. Like we have sites in California,
Wow.
and then the rest are like on the East Coast. Well, we have one in Arizona, so I guess that's kind of close. But yeah, everybody else is in like New York and Massachusetts and Florida and Kentucky.
Is there funding for
Louisiana.
you to go to the sites?
Well, so there could be, but the issue is COVID. Like, you know, we've been restricted for travel for the majority of this project. So like we haven't been able to travel anywhere, so we've had to do everything virtually.
Okay. Well, I don't have an answer because my dissertation was conducted actually, oh man, now this is crazy. I ended data collection March 11th of 2020, and I received an email from UNC saying no more data collection face-to-face March the 12th of 2020.
Wow.
So I believe I don't plan to preach to anybody, but I am very prayerful, and I believe that was God. But nevertheless, I'm wondering, I mean, so like, are you saying even now, since the COVID numbers are kind of decreasing, that they're still not allowing like face-to-face interactions?
So we are allowed to travel now, but I don't know. Like, I don't really know what that would look like, honestly, because I know a lot of hospitals aren't allowing visitors still, but we haven't discussed it like as a team, whether or not we would now be able to go to the sites to do like the mapping exercise and maybe try to get some people for the surveys.
Because Sherita, one of the things that this is Dr. Battaglia's big national implementation project, and what the VA is trying to do is what we're trying to do on part of the VA is not only can we implement something that's evidence-based, but are the strategies that we're using something that can be scaled up and spread, you know, across the nation at very little cost? Because we're really good at doing implementation of evidence-based practices when we spend a lot of money. You know, we're good at that. But COVID has forced us to look at this as, how can we do this as lean as possible? And this is what the innovation that Heidi and Bree and Rachel have come up with, is the idea of flipping it to virtual. And can we still build the same relationships with our teams? Obviously not. In person is better. Bringing lunch is even better. But can we do this because the principles are sound? Right? Relational coordination makes sense. It resonates with people. The mapping experience in and of itself is an intervention, right? Can we do that virtually? That means we could do it 6 times a day with teams across the nation for not a whole lot. And then once we do the mapping, you know, the survey, that's the tricky piece. But if they've seen the value of the mapping, well, they want to see the data, and then they want to engage in the intervention. So that's where we're playing. And I don't know if we'll go back. If we can show that this is effective, what we call relational facilitation, will we use the $500,000 in a grant for travel? Can we use it instead for people or something else? So that's sort of where we live. But I mean, what would that look like in your world?
So I think I mean, I definitely agree with everything that you just said. I'm just wondering, I mean, given the experience that you're currently having, and then the experience I had even pre-COVID, I really wonder, like, if, just doing everything virtually at this time, would be the best way to go. I mean, I know when I went on the different sites, I mean, I had, or not sites, but different units, I had several participants. I would say, well, did you see the flyer? No. And so I was like, I've posted them several places on your unit. What do you mean you didn't see the flyer? And so I apologize. I don't have an answer, because my solution, what worked was I had to do face-to-face relational coordination with participants. And so I know you're probably like, well, gee, why are you here? But that's what worked.
No. Well, what's interesting is Dr. Heba Ali, who is one of the co-authors with Jody Gittell on her most recent book. She did some really interesting stuff with patients and families, but she actually sat with them like one-on-one. So you're right. To get the best data is to do it your way. And so if you can, I think if we could, we would have done it that way. We're just trying to get people to hear about the way we're doing it to help us see if there's another way.
Mm-hmm.
So we're not looking for answers. If anything, I think sometimes we're looking for like a nice ear and a shoulder to cry on.
Right.
This is Kathy. I've been thinking about some of the stuff that you had to do though, and I know right now we don't have a mechanism to follow up in a similar way, but our whole project, we're working through other people. There's really nothing that our team is doing directly to implement the project. We're mostly consulting, and supporting, but we're not the doers. Everyone at the site has to end up doing it. And that's new for us, and it's just in general that's been challenging. But I kind of wonder if there's a way to think about the site taking a bigger role in doing the relational mapping and kind of imitating what you did in terms of walking around the different units and kind of asking, even if they gave paper copies and we entered it into the REDCap survey, to analyze it. But it just seems like, maybe there's some things that we could adjust as time goes on. Unfortunately, we're kind of at the beginning of our project, and there's still a lot of, I don't know, just things that are not very clear. And we're still learning about each other, the sites and us, and the national people that we interact with. So I wonder if we were doing this, 2 years from now, if it would, be different. But right now, our idea is that we would have a baseline and then an end of study comparison. And so maybe some of these things can be done at the end of the study, because we'll have had, 4 and 5 years working relationships. I did want to, I don't know if you have a minute to kind of talk a little bit more, if we have time, Heather. I was kind of interested in kind of your results of what you found, in terms of experienced nurses and satisfaction and intent to stay. I mean, those are kind of interesting findings that I don't know, at least from some of the last time we did relational facilitation, we didn't have that kind of, answers. We just had, we weren't doing the same, obviously, study that you did, but I just thought that those were really great findings that you had.
Thank you. I appreciate that. Were there like some specific questions that you had?
No, I don't, without seeing them, each of the slides again, which is fine, but I'm just saying that I just thought that they were interesting, that some of the intent to stay kind of data that you presented.
Yeah, I was intrigued by also your finding that people with higher education had lower relational coordination. So have you gotten to any of the whys behind any of this?
So, I have not. And I was very surprised by that result because from what I've seen in the literature, the studies that I looked at, for instance, nurses that had higher education, so if they had like a graduate degree, they reported better collaboration with physicians. And so I was surprised whenever I saw that people that had more experience reported lower relational coordination. And I do not have an answer for that. I don't know if anyone else on the call may have, if that's, maybe some research that they've conducted, but I was personally, I was very surprised by that.
Yeah, this is the hard part, right? We start to collect all this RC data and then it's like, well, why? And then what do you do about it? So is some of the intervention piece you're doing just assuming this at your data sites?
So with the next steps, I am really just trying to see mainly the feasibility and acceptability of conducting this research. And so listening to you all talk about the different things that you've experienced as far as data collection and conducting the study virtually, I really, and like after I answered this question, I would really like to tap into maybe some ideas you can give to me. But no, I mean, my main focus for this study is just to see, okay, Sherita, what are you going to find? Like, are you going to find that people, don't complete the surveys? Are you going to find that they do? Are you going to find that you have a Zoom session and no one shows up? Or are you going to find that you have 10 people show up? And so I really just want to, for just starters, I just want to see, will this virtual relational mapping, relational training, relational coordination training intervention, will this be effective? And I'm praying that I'll have a good turnout. I'll see very soon. And so, but that's really my first goal. And then after that, I'll hopefully get a chance to refine this intervention and then conduct future research by modifying maybe what I found in this intervention and improving different strategies and kind of go from there. So did that answer your question or did I not answer your question?
No, that was perfect. Yeah.
Okay.
Yeah, it was very
Okay.
good. No, this has been so interesting. Does anyone else, Marguerite or Bree, anyone on the call have any questions for Dr. House before we wind it up?
I don't, but I just wanted to say, Dr. House, this is fantastic work and just so well aligned with what we're doing. So I really appreciate your presentation and I'm excited to see what's to come.
I agree.
Thank you. I appreciate that. May I ask you all some questions, like a minute or two, just to ask you questions about you, because given that you're doing what I desire to do, so I feel like there's so much I can learn from you. I mean, I've kind of, heard about some of your issues, but what recommendations do you have? What are some things that, I wish I would have known this before I actually started this virtual relational coordination training, pitfalls, things that you feel you've done well? I mean, just whatever you can give me, I am all ears because I am at your feet to learn and listen. So
I feel like this is Heidi. This is a question for Heidi, who I will say, what have we done well? Incredibly flexible. But also we standardize a lot of our educational tools. So even though initially I was sort of considered the expert, then Heidi and Bree and Rachel and another girl, Annie, they went off to the relational coordination training. And so they are now as expert as I am. So we are starting to disperse our expertise so that if anyone has the chance to talk to a stakeholder, they can talk to a stakeholder. And they can have a slide deck if they need it, if they're in the meeting. So that I feel has been unbelievable. But Heidi, you were in the trenches. What do you think?
I honestly think, so I guess initially when I was doing this and I was like, oh my gosh, this is going to be a huge undertaking and also time commitment to do everything virtually, especially, having to do like things like the relational mapping multiple times during meetings. And even like we administer the relational coordination survey in multiple meetings. And so I thought that it would be just kind of overwhelming. But as Heather was saying, the toolkits that we have developed and the standardized presentations we've done are just make everything so much more easy than it would be if we didn't have those. And so I think, I guess my biggest learning thing is to have a very standardized process that you just kind of follow for every site, that can be super flexible as well. But just having that that backbone and that foundation has been very helpful for me.
Wow. How did the virtual trainings go? Like, did the participants seem really engaged? Was it like pulling teeth sometimes, or a combination? Did you offer the training multiple times? Like, for instance, I don't know, like maybe day shift. I'm not sure if you all had to offer night shift trainings, or like for the different study sites. Like, how was that process?
So we haven't offered anything to night shift staff, but what we've done, so first, Heather recorded herself doing this 9-minute, presentation on relational coordination and relational facilitation. And so that's kind of what we start with. We'll play that video during a site meeting, or we'll just, it's on YouTube, so it's super easy to access. So we'll copy and paste that into our team's chat with all of our sites, or we'll email our sites that link and be like, watch this. And so we really focus on promoting that. Mm-hmm. And then the additional training, I do that during site meetings. And honestly, people seem pretty engaged. Like, there's one site that was maybe a little bit mediocre, but they've been a little bit of a struggle since the beginning. Mm-hmm. But the rest of the sites have been really excited about it. Like, one site that we're doing the survey with right now, the main provider doing the intervention was even like, oh my gosh, I can see all these areas of improvement that we should already do. And when we do when you guys present the data back to us, our results, can I invite all these other people to this team meeting so that we can brainstorm together how we can improve our relationship? We're like, yes, please. That would be awesome.
I will say the other brilliant thing that these guys did was that they didn't create a new standalone meeting. So they incorporated their work into standing meetings. That, I think, made a big difference. Sometimes it was harder because maybe some of the people weren't at the table, but it wasn't an extra meeting, which is one of the things that Kathy's entire project about is the quadruple aim, which is making sure we don't burn out our workforce. We want to enhance our workforce. Mm-hmm. How can we make this just part of their routine versus, guys, special session? I think that's one of the most brilliant things we've done.
Wow.
But we only have a couple minutes left, and we're trying to break, give everyone at least a minute to breathe before their next meeting. Any other final thoughts from you, Dr. House?
No, ma'am. Thank you, Dr. Gilmartin. I appreciate your time and for inviting me. It was very nice to see everyone, and I appreciate your support. I'll be reaching out to you again, but thank you, everyone, for your time this evening.
Excellent. Well, we appreciate you doing this work in the military, and I'm sure it will translate over to our world as well, because your current military folks are soon to be veterans, right?
Yes, yes.
Well, thank you. And thank you for joining us.
Great session. Thank you.
Thank you very much. Bye-bye.
Thank you.
Thank you.
Yeah, thank you.
Thank you.